Yeah, I think this is Sanjana. You're ready?
Yes.
Uh,
A very good morning to one and all.
and I will tell Pediatric, I will welcome him and I
Yes,
think
sir. Yes, yes.
Kushal Raj,
Sir.
ready? Yeah, I welcome you. I welcome you to JSS Institute of Speech and Hearing and to this webinar. Thank you for accepting our invitation and to take part in this webinar. I welcome you once again. So, Mrs. Sanjana, please.
Thank you.
Thank you, sir. A very good morning to one and all. I welcome you all to the day 6 of webinar. In the first session today, we have with us Mr. Kushal Raj P. Singhvi as the resource person. The topic that is going to be addressed in this session is pediatric dysphagia and overview. Mr. Kushal Raj P. Singhvi is currently serving as the speech language pathologist, Sage Rehabilitation, Illinois, United States of America. He has completed both his bachelor's as well as master's from the All India Institute of Speech and Hearing. He has been practicing as speech language pathologist and audiologist since 1983. He has worked in acute care geriatric setup in the USA since 1995 through 2007 and in early intervention for over 20 years now. He has been mentoring future speech language pathologists since 1997 and has served as an adjunct clinical professor at Governor State University, University Park, Illinois from 1998 to 2004. He has served as the board of advisors for speech and hearing program at College of DuPage for over 10 years. His purpose in his practice is to respect the individual needs and goals of each family while providing the family with support and ideas so that each child reaches his or her maximum potential in speech, language, and swallow skills. With this note, I welcome you, sir, for the webinar, and I request you to take over this session, sir.
Thank you so much. I appreciate the welcome. Okay. Give me a minute. I hope I can. Oops. Make sure that the camera is powered. All right. You guys can see the screen?
Yes, sir.
Sir, we are able to see, sir.
Okay, I don't know why I'm not getting the feedback on my screen.
So the folder, the PPT is not showing open, but the folder is visible, sir.
Okay. Saransh, you'll have to help me again as usual.
Yes,
what
sir.
should I do?
Sir, you can just open that PPT, sir.
See, it is open for me on my screen.
It is not showing open here. But last time also it was shown open here after
Okay, stop.
20
Give me
seconds.
1 second.
Yes,
Give
sir.
me 1 second. Let's start all over again. I know it's showing on my screen. Let's stop. Let me sign out. Leave examiner. Okay.
So you will sign in again, sir?
Yes, I'm going to sign in again, please.
Okay, sir. Yes, sir. You are signed in again, sir. It's showing.
Okay. Join with computer audio. Okay. Share screen.
Yes, sir. Now your entire screen is visible, sir. You can just open the PPT as you were opening in your any computer.
Okay, let me try that again.
Yes, sir.
Oh boy.
You can minimize this, sir. So don't minimize it, sir.
Okay, there you go. Launch
Yes.
meeting. Open Zoom. Leave and join. Okay, leave and join. It's connecting me now. Still connecting. Give me a minute, please.
Yes, sir. It is connected here, sir. I can see connected from 2 connections.
Okay, but share screen. Continue.
Yes, sir.
Slideshow from the beginning.
Ah.
Oh, not this, sir. This is not the one I wanted. Oh, good Lord. Sorry, guys. Stop sharing. Share screen.
Sir, it was shared, sir. Then again it went.
Yeah. I know. I got the wrong folder. Give me a moment, please. I will get you the right folder. There we go. Thank you very much. Disclaimer. I'm a clinical practitioner. I'm kind of a practicing speech pathologist. So all that I'm presenting is borrowed stuff that I've collected, gathered. So I don't take any credit for any of the things that I'm presenting today. Coming to the presentation, I would like to dedicate
Sir,
my
the
presentation.
screen is not shared yet, sir.
Oh, sorry. Oh man, why is this end show? Okay. Cancel.
So if
So
there
do
is
you
any
want me to
difficulty,
share
you
the
can mail
screen,
us.
sir?
Yes, sir.
Okay, can you see the screen now?
No, sir.
Okay, give me one moment. I'm going to sign out again and
So if you have any difficulty, you can mail us the PPT, sir. We can screen share it to you, sir.
okay. Boy, this is cancel. I'm so sorry. Give me a moment, please. I'm restarting my computer. Just give me a minute, please. All right. Oh, we lost 15 minutes. Very bad. Whew.
You click on share screen and minimize and
Click here to join. Okay, open Zoom. Okay. Okay. Failed to detect your microphone. That is okay. It's test. That's
click
okay.
on share screen.
Marde Sriga.
Then minimize that and
Okay.
open your
Yes, sir.
this
Sir,
one.
don't touch this, sir.
Oh,
Sir, leave it. Sir, this your screen is visible, sir. You can directly open the PPT, sir. You need not do anything with the Zoom now. You can minimize this window. Yes, sir. And you can directly open the PPT. Yes, sir.
Oh,
Now
we
you
got
see
it.
that?
put it on the full screen
Full screen ಮಾಡ್ಕೊಳ್ಳಿ ಅಷ್ಟೇ.
from the beginning. Yes,
Is it visible?
Yes, yes
Okay.
sir. It is
Finally.
visible.
Thank
Yes,
you.
sir.
Thank you very much. I'm sorry. I apologize for the technicalities. I'm not that savvy with computers. Anyways, I'm going to start straight away. Like I said, the whole material is nothing is my own research work or anything. I've borrowed everything and I'm presenting what clinically I'm working with. Would like to dedicate my presentation to my teachers from Aish, Dr. Ratna, Professor M.V. Sushila, late Professor Sushila, ENT surgeon, wonderful person, Dr. Vyasmurthy, and of course, Dr. Natraja. It's been 44 years that I joined Aish, and so proud to see Dr. Natraj having brought up this institution to this caliber to 20 years. Hats off to you, sir. And always happy to kind of talk to Dr. Ratna every time I come to India and learn from him every time. So my idea is to talk to you kind of brief history about dysphagia, and we'll talk about the basics of dysphagia, oral phase, pharyngeal phase, esophageal phase, assessment, and intervention techniques. So it's kind of way back in 1930s that speech pathologists began to address swallowing along with speech in children with cerebral palsy. In 1952 and 1956, Journal of Radiology kind of published 2 articles, The Protection of Laryngeal Airway During Swallowing, and another one, Closure and Opening of Laryngeal Swallowing during larynx during swallowing. Closure and opening of the larynx during swallowing. Fast forward 1983. Behavioral management of dysphagia, done primarily by speech language pathologists in United States, has been accelerating since Jerry Logeman's first book was published in 1983. In retrospect, this seminal publication appears to have legitimized the clinical activity of speech language pathologists in swallowing disorders. She provided sufficient guidance to give other clinicians the confidence necessary to expand their clinical skills set and expand their scope of practice. I was very lucky and fortunate to have attended her workshop way back in 1997 or 98. So this kind of historic bits and pieces from individual clinical researchers and small groups, like-minded individuals, have now matured into interdisciplinary international research and clinical program. Way back in 1992, the first annual Dysphagia Research Society, DRS, meeting was held in Milwaukee, Wisconsin. In 2004, the Specialty Board on Swallowing Disorders recognizes first board specialist. It's called BRS-S. The three major factors which are closely interrelated must be considered in the assessment and management of feeding. These include oromotor development, availability of nutritionally adequate food such as proteins, carbohydrates, dairy, micronutrients, fiber, etc., and the interactive behavior of the caregiver and child. The long-term prognosis for development of normal oromotor functioning and feeding relates directly to the underlying medical and neurological problems affecting the infant and child. Initial symptoms are not as important in this regard. The earliest communication between the parent and an infant occurs through feeding. Thus, a feeding problem in a newborn period is usually perceived by parents as a very significant concern. The ramifications of abnormal feeding can permeate all aspects of their lives. However, it is important to note that improvement can be anticipated as the central nervous system matures, even in neurologically impaired children. The development of increased muscle strength and learned compensatory movement will also help to improve on early feeding problems. Sadly, for some children, feeding problems may become more prominent or new problems may arise as the child ages. The early promotion of optimal oromotor function in infant is a higher priority. Unless effective changes are made early, oromotor and feeding problems in infancy frequently results in cycles of forced feeding and inadequate nutrition later in life. Delay in the development of sensory motor skills can result in longer feeding times and also increased tension in the caregivers, further exacerbating the feeding problem. Infants gain all their nutrition through breast or bottle feeding until they are at least 6 months of age. The ability to suck successfully from breast or bottle requires the infant to coordinate 3 actions: suck, swallow, and breathe. Suck is accomplished with slightly different motion on the breast compared to the bottle. But essentially, the lips must close on the nipple and the tongue moves in and out in a suckle motion and presses the nipple against the roof of the mouth, creating pressure on the nipple. As the jaw moves down, it helps create suction to pull the liquid into the mouth. The infant then has to swallow the liquid. The infant must stop breathing during each swallow and then breathe after swallowing. The suck, swallow, breathe sequence then starts again. Many things can interfere with this sophisticated system for swallowing. Okay, this is the slide of Jerry Logeman. Now we're looking at the kind of the adult oral structure, the pharynx and the oral versus the neonatal oral structure. If you notice that the oral cavity looks smaller because of the infant's tongue filled with mouth and rest. Oops. Oh, wait a minute. Oh. All right, thank you. The oral cavity of an infant tongue fills the mouth and rests more anteriorly. Infants have sucking pads, and that, of course, helps to latch onto the nipple and have a good ability for him to extract the milk, which disappears within 4 to 6 months of age. Size of oral cavity decreases due to relatively small mandible. The close proximity of tongue, soft palate, and pharynx with larynx facilitate nasal breathing. only for about 3 to 4 months of age, then infant begins to breathe from mouth and nose both, as you can see that. The phases of swallows, of course, some places you might see that there are 3 phases: oral phase, pharyngeal phase, and esophageal phase. The oral phase is where sucking, chewing, and moving food or liquid into the throat. Feeding is a part of the oral phase. I've kind of made it oral preparatory phase, where you see that the manipulation of the mouth, mastication or chewing, and if necessary, over to reduce food to the consistency which can be swallowed. That phase is voluntary. The tongue propels the food posteriorly until the pharyngeal phase and is triggered. So now with the pharyngeal phase, it's mostly an involuntary movement. Once the head of the bolus, cohesive bolus, is brought too close to the pharynx. And of course, the esophageal phase is an involuntary phase where the food moves through peristaltic movement down from the cricopharyngeal juncture or the upper esophageal sphincter through the esophagus to the lower sphincter. Just for the convenience of the younger students, this is the picture of the oral phase where you have the food bolus. The chewing happens. In case of infants, they just manipulate the food bolus. The tongue raises up and moves backwards. As it moves backward, the food bolus moves back and transfers. The lips and the cheek serve to maintain the bolus in the oral cavity. The tongue pushes the bolus posteriorly, and then the vilopharyngeal closes, makes it an airtight seal, an opening so that nothing can escape through the nasal cavity. This is the pharyngeal phase where the food enters the passes through the fossil pillars to enter the oropharynx. The epiglottis in adults, of course, inverts to cover the vocal folds, preventing material from entering the laryngeal airway. In infants and toddlers up to 3 years of age, epiglottis doesn't have that function. The bolus is directly posteriorly through the cricopharyngeus into the esophagus, and that's how it travels down. And this is, once the food is down here, we have no control on that. We'll talk about the assessment part of it. For a safe swallow, what do the babies need? They need an intact neurological status, development of sensory system, respiratory function, digestive tract, joint stability, and tone of the muscles. So some kids might have difficulty with the tongue tie. If an infant immediately has trouble with sucking in the absence of any obvious medical or developmental problem, the infant may be presented with restricted frenum or lip or tongue tie. For infants who are breastfed, the mother may experience unusual nipple soreness. The frenum is the little piece of tissue that connects the top and bottom tip of the gum and the tongue to the floor of the mouth. If these are too tight, then the infant can get a good latch on the nipple or cannot adequately move the tongue. This restriction may not be obvious, but a speech-language pathologist who works with infant can help decide if there is a problem. It is then easily corrected with minor surgery. Just want to add a personal note. My grandson went for a dental checkup. He's 2.5 years old. And then the dentist said that he needs to get his tongue released and the upper lip released. My daughter-in-law, who's a pediatrician, kind of called up and said, "Dad, the dentist said this." I said, "Are you kidding me?" Aditya, my grandson, has a vocabulary at 2.5 years, close to about 250 words. He uses 2- and 3-word phrases, clear speech, absolutely no problem. He can eat most consistency of table foods, self-fed since 10 months of age. I don't know. I'm a little surprised. Anyways, explained to my pediatrician daughter-in-law, and she was also taken back, and she's not going to that dentist anymore. Now, coming to the cleft lip, cleft palate, because the lip and palate, the roof of the mouth, are essential in the helping the infant create a good seal and suck. A cleft of the lip and or palate can cause difficulty. However, most infants with cleft lip palate can feed successfully with right intervention. A speech-language pathologist can help determine if the infant will be able to breastfeed and what kind of nipple or feeding systems will be needed to successfully bottle feeding. And comes to neurological conditions such as cerebral palsy or Down syndrome and other neurological conditions or syndromes that affect muscle tone can make it challenging for the infant to get good seal on the nipple or effectively pull milk from the nipple. Cardiac problems. Infants with cardiac problems often have a hard time during feeding. They may become fatigued and not be able to finish the feeding because infants stop breathing each time they swallow. This can cause a change in heart rate. Some compensations like frequent breaks during feed can help the infant be successful. Premature birth, difficult delivery, aspiration, hypoxia, they can also impact child's feeding. Postural control because of prematurity, breathing regulations, all this can certainly impact their oral feeding. Cardiac issues, like I just mentioned a minute ago, starts with limited respiratory reserves, difficulty regulating cardiorespiratory function. It impacts energy, endurance, intake, and so the could be other problems, breathing problems such as asthma, the head and neck concerns, torticollis or any muscle stiffness, muscle weakness in the face and neck. Medication, if the child is getting some side effects, could also cause other issues. Digestive tract disorders are one of the bigger things that are impacting the feeding in newborns and the infants. I've listed the whole different conditions where you can see that all these conditions have to be ruled out, where the GI specialist has to be a team member when any of these things are there. Minimizing impact of medical history on feeding. Does the feeding disorder have a physical component? Yes, feeding is a process that uses all organs, all senses, and all muscles. I will be talking a little bit more about the senses when I'm talking about the autism. Feeding is the most complex task we do as humans. What conditions impact ability to eat is very important. Breathing is body's number one priority and eating is the second. We have to even to look at children with this drooling. Is it the postural control that is poor, or is it oral sensory responses? Is the child doesn't have sufficient oromotor skills, or the swallowing ability or to trigger the swallow response is delayed, or the cognitive level is so low that the child is not aware of what needs to be done, or is there a structural problem? Again, medication and hydration can all could be the reasons for drooling. So impact on feeding. Has the child learned to coordinate the suck, swallow, breathe sequence is very, very important. This is the foundation of pre-feeding readiness or oromotor skills. Is there these foundations strong there? What are the child's developmental process been like, especially in the neonatal intensive care unit and the pediatric intensive care unit for extended period of time? I did work with a child about 2001. He was born only 12 ounces. 12 ounces, you can imagine just this size. He was in the neonatal intensive care unit for close to 5 months. When he came home, he was about 5 pounds. Such children have a lot of other issues involved with the, of course, he came with a G tube and 24/7 oxygen because lungs were, and by the way, he was born at 27-week gestation. Really, really preemie. All this has effect in further as they grow. In early intervention, I saw him till the age of 3 years. Of course, by the age of 3 years, he was eating all regular consistency food. His speech language skills developed age appropriately. Again, growth and development of sensory system is critical for transitioning to textured food. Feeding has a learned component. It is reflexive until age 6 months, and then it is a learned behavior. Premature or neonatal intensive care infants. So their medical instability, their neurological immaturity, abnormal muscle tone, immature or altered oral mechanism, poor oral skills for sucking and swallowing. Either they could be oral hypersensitivity or hyposensitivity. It kind of really plays a big role in their feeding. The role of speech language pathologists in neonatal intensive care unit is very crucial. Infants born prematurely are not able to safely and effectively eat by mouth until they achieve physiological stability. This milestone occurs around 34 weeks gestation age on average. So if someone is born at 26 weeks, you're expecting him to be another 18 weeks before he kind of reaches the physiological stability. Testing the infant's reflexes in the mouth, the phasic bite reflex, the tongue protrusion and transverse reflex, the routing reflex, the suckling reflex, all these have to be evaluated. Providing the infant with an appropriate sized pacifier in order to provide positive oral experience such as non-nutritive suckling during gavages, that is when the child is having tube feeding, just to functionally get him to, you just give a pacifier, you got to find out what pacifier size is, and that's again responsibility of the speech language pathologist. Dipping the pacifier in breast milk or formula to allow the infant a taste while sucking. Monitoring for changes in infant's alertness and state during activities and care routines, and providing intervention to help the infant maintain the desired alertness level as needed. Monitoring the infant's oxygen level, heart rate, and breathing rate. These are the vital signs. So the nursing staff is, of course, it's an intensive care unit, neonatal intensive care unit, they're always there, but you're always working along with them so that you're monitoring their heart rate, oxygen level, and breathing rate during the intervention in this to maintain his physiological stability. Speech language pathologist performs an essential function as a communication specialist during the transition to oral feeding in the neonatal intensive care unit. It is part of the SLP's role to recognize and interpret the subtle communications that the infant provides during oral feeding and adjust the feedings as needed to help the infant achieve safe and adequate oral intake. The speech pathologist may recommend various instrumental swallowing assessments such as video fluoroscopic swallow study to assist in their diagnosis and management of infants' feeding and swallowing difficulties. The speech path will also assist in making appropriate referrals to discharge to early intervention and other follow-up services to continue providing support for the infant after discharge. And that's where kind of 0 to 3 age that I work in early intervention, the child comes from the hospital, whatever stay they need to be there, some stay for a week, 2 weeks, to up to 4 months, depending on how severe the problems are. Some of the signs of feeding and swallowing disorders could be the child arches her or his back or stiffens when feeding, cries or fusses when feeding, falls asleep when feeding, has problem breastfeeding, has trouble breathing while eating and drinking, refuses to eat or drink, eats only certain textures such as soft food or crunchy food. Takes a long time to eat, has problem chewing, coughs or gags during meal, drools a lot or has liquid come out of his or mouth or nose, nasal regurgitation, gets stuffy during meals, has a gurgly, hoarse or breathy voice during or after meals, spits up or throws up a lot, and is not gaining weight or growing. Some of them are very clearly showing that there are signs of aspiration happening or penetration of food liquid happening. The last one is certainly spits up or throws up a lot, shows that a GI specialist needs to be consulted. So the studies are, of course, modified barium swallow study, kind of, again, this is for the purpose of students early in the program. A child eats or drinks food or liquid with barium in it. Barium shows up on an X-ray, so the SLP can watch these 3 phases of all the 3 phases. Basically, when they swallow, there is a video camera that's recording the whole swallow mechanism. A radiologist has to be present for the video swallow study. It's been conducted by the speech pathologist, but the radiologist is present as for the X-ray machine part of his concern. And of course, later on, they play the tape frame by frame. There are 28 frames per second, and they see how the food is traveling, whether it's a liquid or solid, how it is traveling from oral phase to pharyngeal phase and to the esophageal phase. They can see all the 3 phases, because it is barium coated. In older kids or in adults, you could use an endoscopic assessment, because you have to put a tube into with a scope into the nose, and this can be done by the speech pathologist most of the time. But then it has little drawbacks. I personally don't like it for younger children because it irritates. It's not a normal thing. You can't see the oral phase. You can only see whether anything is penetrating during the pharyngeal phase. that comes the intervention part of it. So basically, we need to establish the suck, swallow, breathing interaction to be taken care of. Influence of illness and immature central nervous system has to be addressed by the neurologist and the medical team. Multi-system integrated nature of feeding is involved here. Interaction between the medical diagnosis and feeding therapist. We all work together. And as we go forward, I'm going to talk more about what are the things that we do. So we start the evolution of intervention is functional perspectives, modify utensils, provide adaptive equipment for sitting, positioning, holding, neuromotor perspective for positioning, alignment, movement, oral control. Of course, our population broadens due to the advances in technology and medicine. So we have to treat a child as a whole. It just can't look at, okay, feeding is my part. I don't care about the breathing. I don't care about the motor control. I don't care about the sitting and positioning. No, it doesn't work that. You have to look at child as a whole. Your focus on many systems are involved. Like I said, the respiratory system, the neurological system, the muscle system, the kid's digestive system, everything is involved. We have to work as a team. We have to recognize that feeding successfully depends on much more than just age, weight, and sucking ability. So these are the physiological cues. He tolerates full eternal feeds, has stable respiratory system, tolerates gentle handling. This is again for a small baby. Is able to transition to an alert state, has the ability to lick, nozzle, or suck non-nutritively. So if you put a gloved finger or a pacifier, he can suck on it. So behavioral is roots in response to touch around the mouth that do this. They kind of do that. Place hand on the mouth and they pucker their lips, lip smacking, tongue protrusion, searches for nipple when kind of placed on the breast. I just want to share the 5 types of rooting reflexes. There we go. So we have a gag reflex, the phasic bite reflex, tongue protrusion and transverse, then rooting reflex, suckling reflex, and swallowing reflex. Gag reflex diminishes, it persists forever. Phasic bite reflex diminishes from 9 to 12 months. The trunk protrusion and transverse reflex, which is when you touch the tongue or the lip, it diminishes 4 to 6 months. And the rooting reflex, that is when you touch, they move their, when you touch the corner of the lip, they will move their mouth or kind of show that they are getting that diminishes 3 to 6 months. Suckling reflex is the nipple in mouth or stroke the kind of top of the tongue. It diminishes from 6 to 12 months. Swallowing reflex is one which persists. Of course, there are cranial nerves that are involved in the swallow reflex, 5th, 7th, 9th, 10th, and 12th. These are the 5 cranial nerves involved in swallow mechanism. You can understand how important this swallow mechanism. So reflex interventions, we can always help them positioning. So after feeding, do not lie them down. Anybody who has reflex problem, acidity problem, should not lie down immediately after eating. So having them up for 30 minutes helps them to kind of settle down. Limiting air intake when feeding is also very important with infants. So when you're doing bottle feeding, you're pacing the child. When you're pacing the baby, you got to make sure that you don't give too much of air. Pace in such a way that he doesn't take too much of air, but at the same time, you're pacing him. Bottle and nipple changes might be helpful sometimes. The formula changes when appropriate. Pediatrician will look into that. If there is more problem with reflex, sometimes thickeners also help. Scheduled intake, you have the timings when to feed them, when to kind of, that helps to avoid the reflex problems. Medical management, like I said, the GI specialist might have to, and there are surgical procedures also sometimes recommended, not too often. So the 2 key strategies as far as the feeding is concerned, when medically everything is cleared. So no neurological issues, everything is fine, now it's cleared. Positioning and flow rate. So airway maintenance and breathing regulation is very, very important for safe swallow feeding. So swallowing safety, sitting, overall organization of the infant, also alertness, should not be kind of sleepy. Most of which what infants do like during feeding is related to airway maintenance or airway protection. Having them upright, holding position. I'm going to show you some pictures also. When you're feeding, those are the safe ways of feeding. So head and neck positioning influences airway calibration, swallowing, and I'm going to just move on. Here we go. This is intervention strategy. That's a semi-upright cradle and on feeder's lap facing the feeder. But then disadvantages, typically it's a more shallow breathing. Head can easily be extended out of alignment. Gravity can pull the tongue into a more retracted position. Food can pool, and unfortunately, too much pooling is not good, and there is a situation what is called as premature spillage. So before the actual swallow takes place, because of the food accumulated in the molecule, it can just squeeze by the time the next swallow is happening. That could be an issue. So pooling should not happen. This is more safer. It's easier for child to breathe. Lung compliance is increased. Airway resistance is decreased. Better head and neck alignment. Easier easier to control fluid. Increases subglottic air pressure for airway protection. One of the most critical factors, if not the most critical factor for safe feeding is the flow rate. The greatest obstacle to safe and successful feeding is a high flow that may flood the pharynx, triggering repeated swallow and leading to interruption of breathing. And if the child has got already issues in neonatal breathing, if he holds the breath for an extended period of time, it could be fatal, it could be really bad. So consider normal development options, adapt to sitting and positioning. You guys can read that. It's 1 to 3 years in the arm, and the bottle should not go it's kind of the ear and above. You're holding the baby in your arm. Sensory normalization hierarchy, we'll kind of talk a little bit when I'm talking about the feeding with autism. Drooling intervention, I'll leave that for now. Pacifier, it's calming and self-regulating. It's good for reflex and to kind of help to kind of manage it. But the disadvantage is those with impaired feeding skill may rely on pacifier longer than typical, thus lacking the ability to transition to more mature types of oral exploration. Even here, I would like to mention the bottle feeding. Typically by 11 months onwards, you should start discarding the bottle feeding and move on to soft sprout, or check what kind of a sippy cup or sprout bottle the child can transition to. Again, it is trial and error. You have to find out what works for the child. But bottle feeding is, again, you're holding, the child holds the nipple, extracts, gathers it, and then swallows. With sprout bottle feeding or with sippy cup, it's kind of a continuous make, just swallow and it goes. You're extracting and swallowing. Oops, sorry. Prolonged or frequent use may inhibit the developmental progression of tongue control needed to transition from sucking the anterior midline to the chewing posterior lateral, and that's what I was talking to you about. That extended use of pacifier or bottle feeding can delay the chewing. These are some of the excellent oromotor exercises: retraction, protrusion, pressing the lips, using a tongue depressor, resistive, and then to increase the strength of your lip muscle, blowing air into the cheeks. Might not be possible with newly born or new infants, but older kids certainly can do. Tongue extraction, retraction, and then of course side to side movement, pushing the cheek, moving the tongue around the oral cavity, clockwise, counterclockwise. All this is very good to increase the strength, rate, range of motion, and coordination of tongue, cheek muscles, because pocketing happens because of the weakness of the cheek muscles. So once the tongue muscle and the cheek muscle both have to be strong. Once they can have the food bolus, they can squeeze it tight and swallow it. There should be no residue left between the sulci, between the gums and the cheek. And these are the jaw exercises helping for chewing and mastication. So these are evidence-based devices that they have been in the market. The first one is, of course, the Iowa Oral Performance Instrument. This can measure tongue strength and can also measure lip strength. For tongue strengthening, an individual will place an air-filled bulb in the mouth and press this against the roof of the mouth with the tongue for a prescribed duration of time and repetition. With this device, tongue force is measured in kilopascals. Visual feedback is shown in form of a light array on the handheld set. A clinician can set and modify the target pressure as needed. The newest version allows patient to use the device at home. A new feature coming will allow the device to store data and generate reports. The bulb is for individual use, but the handheld device can be used with multiple patients. Cost is only between $1,000 to $2,000. The second device, the Tango Meter, is a handheld biofeedback device that measures and exercises tongue strength and endurance. The device connects to a user's smartphone or tablet and is compatible with a free downloadable app. The app contains 4 assessment and exercise modules that allows users and their clinician to easily adjust settings, show biofeedback, store exercise results, and send a data report from within the application. The bulb is for individual use, but again, the handheld device can be used with multiple patients. With this device, tongue pressure is measured in kilopascals, under $300. So this is the Swallow Strong system, has a custom molded mouthpiece, tablet, and a user-friendly software. A clinician will help to mold the mouthpiece to the roof of the patient's mouth prior to initiating therapy. There are 4 sensors on the mouthpiece to target the front, back, and both sides of the tongue. The patient will place the mouthpiece against the roof of the mouth and press the tongue against the sensor shown on the tablet. The software program automatically calculates therapy targets and shows online visual biofeedback. With this device, tongue force is measured in using hectopascals. Data is collected and can be shared with clinician to measure progress over time. The mouthpiece is for individual use. However, system tablet software can be used with multiple patients. Price is not mentioned. Anyways, the last one is, description. Tongue press is a resistance exercise instrument designed to increase tongue strength. It uses water pressure to provide resistance to the bulb that is placed in the patient's mouth and pressed against the roof of the mouth with the tongue. An indicator on the instrument rises in direct relation to the pressure applied. Resistance is applied by tightening the air valve. The tongue press provides visual biofeedback, however, does not provide unit of measurement or record the data. This company reports this device can be used with adult and children. This is an individual use device, only $22. Anyways, I'm sure once these devices come to India, the genius mind of the engineers and people in India will kind of find what we call jugaad, and they will do a better job for much, much cheaper price. I have full confidence in that. So now I'm going to talk about the dysphagia team. Dysphagia team is led typically by a speech language pathologist. There could be an occupational therapist, a physical therapist, a physician, or a nurse, that is a physician nurse practitioner, a dietitian or nutritionist, a developmental specialist, a social worker, a lactation consultant. Typically in a neonatal intensive care unit, these are the team members. Even if the child needs services after the neonatal intensive care unit, sometimes 3 or 4 of them, I work with sometimes 3 or 4 of them, occupational therapist, physical therapist, and a dietitian are typically the people I work with in practice of early intervention. Okay, now, oh, no, wait a minute. Stop sharing. I've got to go and oh, maybe I have to sign out from this. Give me a minute, please.
Sir, you need not sign out, sir. You
Oh.
can directly open it, sir.
Thank you. You caught me on the right time. So again, your screen is. I'm stuck.
Sir, you can stop sharing, sir.
Yeah, I will have to stop sharing. Okay.
Yeah, now start share a screen.
Yes. Thank you. There we go. So this is Advocate Healthcare. I've been attending their workshop for the last year and a half from home doing nothing. This is a very good one for autism, basically for autistic kids. The prevalence estimates the selective acceptance of food or refusal to eat many or most food in children with autism spectrum disorder vary, but researchers consistently have found that more than 50% with ASD limited food acceptance. I was talking about these sensory issues. So these children have atypical sensory processing. Both touch, taste, smell, vision, and sound, everything can be a problem for them. So this is what it is. For us, it is this. For them, it could be anything. So internal cues could be pain, digestion, hunger. Then they have problem with social and language difficulty. Now, social reciprocity and social interaction impacts mealtime. Again, as you know, children with autism disorder are kind of social skills and a big issue. So that's another problem there that is impacting their feeding indirectly. Difficulty communicating discomfort or understanding instructions relating to eating is also a problem. Nice picture of this child kind of. So medical and motor challenges. I was told that children with autism have 8 times more, please listen, 8 times more GI issues compared to a regular growing typical infant or a child. Again, use of elimination diets, gluten-free, casein-free, or both, and may further restrict food repertoire. Then comes the rigidity part of it. They have very rigid, they want it in a certain way. I'm sure if you, these days there are a lot of movies that have come up on autism, autistic children. They want a certain, I worked with a child that we were trying to work with French fries from 5 or 6 different stores. We tried to put it McDonald's fries, other fries in the McDonald's pouch. The kid would recognize. Just a 3-year-old kid, he would recognize. Not even 3 completed, 33 months. He would just throw it. You can have from 5 Wendy's, from Burger King, from McDonald's. Only McDonald's you would, amazing. So the intervention is needed. I would give you some time, guys, to read it from picky feeders versus problem feeders. This is what you see in the picky feeders, and this is the problem feeders. And this is the information you need. Does the child consume food from all groups? We're talking about the proteins, carbs, dairy product, and fiber. What foods are missing? If the child is self-fed, again, these are the information that helps to provide effective feeding therapy. So how can therapists help improve meal hygiene, expanding food repertoire, developing oromotor skills, building the team? When you say improving meal hygiene, setting the stage and table for success, establishing, this holds good for almost all children. So infants, toddlers, especially infants and toddlers, establish consistent meal and snack times. Avoid gazing, reduce distraction during mealtime. I mean, I have seen so many families, including my own family, that television is on, bribing has to take place for the kid. I mean, all kind of bribing happens. You should stop all those things very early. Do not start the bribing culture so early in terms of feeding them, and it's find the root cause and try to work in a way that you don't do that. Reduce distraction during meals, no tablet, no television, nothing. Facilitate postural stability with sitting. With children in this, if you feel that seat is too big, you can take small towels, roll them and put them sideways for stability. You don't have to have a fancy chair like this. You can have a regular smaller chair, but you can put cushions or something to give stability. Always involve the child in food preparation. This is 2-year-old and 3-year-old. When you're cooking, you can just involve the child to some stage wherever possible to make him feel or feel heard that this is what is being cooked. Now, this is typically recommended for children with autism. Plan for social meal meeting where everyone eats and the same thing. This is important. So again, expanding food repertoire and food chaining. So basically, beginning with an accepted food, let's say the French fries, and then you start giving him sweet potato fries, and then you move on to make it mashed sweet potatoes. So this is food chaining. So to give another example for kind of an Indian setup, you could start with roti, move to paratha, and then you can go to naan. Or even dosa. We can have from rice dosa to ragi dosa to uttapam. This is the hierarchical desensitization to the food. I just told you guys that I'm going to show you later on. I did attend this workshop also. It's a very expensive, the whole plan that they have. You have to have same color food of carbohydrates, proteins, dairy product, and fiber. And then you have to have kind of 5 or 6 items. If a child refuses one, do not present that. Come back with that. When you look at the families where they have difficulty in having a decent 2-square meal, and this it's expensive. It's, I think, $7,000 is the program if you have to go there. So anyways, the point is that let the child first look. And this, I apply this even with the regular kids. If they don't like certain food, I just let them put the food on the table by their side. If they look, I'm happy. And then gradually they can eat what they like to eat. And then at some point, I'm touching the food. I'm not asking him to touch. I'm just playing and keeping it close to his reach or her reach. And they touch the food. And then next stage is kind of picking up and they smell the food. And of course, then as parent or others, they pick up the food, they kiss it and they eat it. Oh, it's so yummy. It's yummy, yummy. And the kid, he picks up and just kisses and puts it down. Honestly, I have a child who was not able to, he was tolerating only liquids. He's 26 months now. I've been working for the last 4 months. Since 22 months age, he would not take any solid food, even stage 2 foods. It's like mashed banana, even that only liquid. Now he takes fruit puffs, veggie puffs. He will tolerate some crackers and some cookies selected. So all other foods that his mother eats, now he licks it and puts it aside. Before he would whine, cry. And now he is able to look at it. He's touching it, he's smelling it, he's kissing it, and he will lick it now. So almost all these are gone now. He straight away picks up a food, licks it, and does a kind of funny face and then puts it aside. We're very happy with it. Of course, next is the bite stage. They're talking about developing oromotor skills, postural stability, 90 degrees angle. So if you look at this 90 here and 90 here, foot stability is very, very important at every stage. So make sure that this hip is 90 degrees and this is 90 degrees. Working on jaw strength and stability for biting and chewing. Lip closure during chewing and swallowing. And some of the tips and tricks. This is a kind of a mashed bag. You can put pineapple, you could put watermelon, you could put mangoes. It's kind of a small sack. Honestly speaking, in India, I know in my house back in India, they use kind of a plastic bag for the tap water. You could throw that fruit, whatever you want, tie a knot it and give it. Of course, you don't have to spend $12 or $15. It's kind of, we're talking about whatever amount, translate to 1,500 rupees. You don't have to do that. You can just use that 5 rupees, 10 rupees plastic, the plastic bag with the mesh, that is, put the fruit into it and give it to the child. Building a team, of course, like I said, because higher prevalence of GI symptoms and disorders are likely associated with autism spectrum disorder, allergist, registered dietitian, and speech language pathologist for the video swallow study part of it is a team there. When it comes to therapy, the speech language pathologist, the occupational therapist, and the behavioral therapist are kind of the core members of the team. So this is what you build the core team and take it from there. I would like to share one quick video and then we should be done with this. Let me go back there. Eating at the table. Eating at the table. So just kindly, this is most of the time when I eat food, I should sit at the table, no running around on the couch watching the television. In the balcony, people are walking by, and I mean, I've seen that happening in my own family back in India. Kid is just to keep him occupied, to distract feed him, then they keep feeding him. Don't do that. Let's sit at one place. If you want to put a chape or mat and sit down, that's fine. Whatever you want to do, have one place. Most people sit in the table for meals like breakfast, lunch, and dinner. You can eat a snack in other places. So maybe a popcorn or something to eat or a watermelon. It might be living room or outside. My mom, dad, and other family member will tell me when I need to eat at the table and when I can eat somewhere else. So you cannot take frequent breakbacks, chasing the kid around and then coming back, and it's fun, especially after learning all this. And when I come home and I see all this happening, it's fun. And then the answer is, otherwise he will not eat anything, he'll go hungry. When I'm asked to eat at the table, I can try to stay there. If I need to move my body, I can ask for a break. So this is a very good concept, and this is good for all the therapies, not only for feeding. First you do this and then we'll do this. So here's the board, communication board. Let's see. Oops, come on. Yeah. So you can take pictures, then we can go a reading time, or we can have a phone time or a tablet time. This is meant for autism kid because of being non-verbal. So you have all these pictures. You can do whatever you like to do with your child. You can put pictures, or you can use any other modality. This is an easy modality even with the kids, that let's first eat and then we'll do this. Let's read this first and then we'll do this. Let's finish the homework and then we can watch TV. Again, you can have some kind of a schedule there, that if you want in between, as you're working with the child, you can always say that, okay, you know what, you take 2 bites and then we'll go for a walk, or you take 5 bites and then we will do the watching a clip for 2 minutes. You start from there and then you gradually come down to absolutely nothing doing. Now we have to eat a whole meal. So if the child is there, it's kind of gradually you can move forward in that way. I'm going to stop here. I would like to thank Professor Nataraja for giving me this opportunity to interact with you all.
Thank you, Krishna. I mean, you have put in all your experience and made our students as well as the participants to get used to. Yeah, thank you.
No
sorry,
problem.
Don't
say sorry. No. I just wanted to make it. I'm sorry that I could not sign in time. I could have shared some more information, but
very informative, and maybe we can organize one more session sometime. Definitely, we will depend on you again for a similar webinar, specifically on swallowing disorders. Thank you for sparing your time.
No problem. I'll just answer this question: how to teach chewing solid food in an autistic child? Very good question. I don't know still if you have that question. I explained to you how you take the food from Dr. Meghashri. I showed you the chart how to kind of take the child from not eating anything to it's going to be a very gradual process. And I'm working with 2 kids with autism, and I've reached the stage, like I mentioned, that now they are licking, but they are chewing on fruit puffs and veggie puffs. The good thing with fruit puffs and veggie puffs I use with almost all young toddlers is they melt with just a drop of saliva. So with others like Cheerios, I use Cheerios also with infants and children, but the difficulty is they don't dissolve. With fruit puffs from Gerber, and there are a lot of companies which make this, they are like a star, small star, like your gem size, but they can be crushed with your hand, you can crush into powder. As soon as it goes in the mouth with saliva, they dissolve and disintegrate. So you could start with that, or you can, in India, you could just start using crackers. Again, salt and crackers, or I'm thinking about Britannia biscuits. Those are good to start off with. Just crush and then go gradually. Start with stage 1 food, stage 2 food, stage 3 foods, and then of course cut chopped up foods. Did I get the answer? I don't know whether I could convey it or not.
Yeah, we will give her your email ID also. Maybe
Sure,
she
sir.
can contact you. Thank you very much for keeping you awake late
No problem,
night.
sir. Thank you. Always a pleasure and honor, sir.
Anyway, thank you. Over to Mrs. Sanjana.
Thank you, sir. Thank you very much for an informative session. On behalf of JSS Institute of Speech and Hearing, I request you to kindly accept the letter of appreciation, sir, for being the resource person in today's webinar.
Thank you very much. How do I accept it? I just have to say yes. That's
We
all.
will mail it to you, sir.
Just give it to my grandniece is there. She can take it, or I will collect it from Dr. Natraj.
Yes, sir.
Just let it be with him.
Thank you.
It'll be
Thank
safer.
you very much.
Yes, sir.
Thank you so much.
Thank you, sir.
Mrs. Sanjana, we have Dr. Venkatkari waiting. Dr. Venkatkari?
Yes, I'm here.
Yeah. Welcome to Mysore JSS and to the webinar.
Thank you.
Yeah. Thank you for accepting our invitation and to take part in this webinar. Over to Mrs. Sanjana, please.
Thank you, sir. I welcome you all to the second session of day 6 of the webinar. We have with us Professor H.S. Venkatgiri, who will be addressing the topic Fluency-Focused Adult Stuttering Treatment in the Post-Pandemic World. Professor H.S. Venkatgiri is currently serving as the Associate Professor, Department of Psychology, Iowa State University, United States of America. He has completed his BA in Psychology from University of Mysore. He's completed his MSc Speech and Hearing from University of Mysore as well. He has done his PhD in Speech Language Pathology from the Bowling Green State University. His research interests include fluency disorders, augmentative and alternative communication, speech synthesis and recognition applications in communication disorders, speech production theories and models. The research front, he has over 26 publications and over 516 citations to his credit. With this brief note, I welcome you to the webinar, sir. I request you to kindly take over the session, sir.
Thank you, Ms. Sanjana. And can everybody hear me?
Yes, sir, you are audible, sir.
Oh, okay. Thank you. And let me see here. I will share my screen. Okay, so I have shared my screen and I hope everybody can see it. Good morning to everyone. It is actually...
Yeah, we can see your slides.
We can see, yeah, okay, thank you. Yeah. So good morning to everyone, and I hope all of you are doing well,
Yes,
and
sir.
all your
It's
students
a
are doing well in this very strange environment that we are living in right now. And congratulations to Dr. Nataraj and to the JSS Institute of Speech and Hearing for completing 20 years of providing quality education and clinical services. It is, I have always enjoyed visiting the Institute and talking to students, talking to Dr. Nataraj and other faculty members. It has been a pleasure collaborating with Dr. Nataraj also and other faculty members in research, in stuttering and in other areas. With that, as mentioned, my topic is stuttering treatment in adolescents and adults in the post-pandemic world. It is often said that there is a silver lining in every dark cloud, meaning that you can find something positive even in a disaster or in a calamity or something like that.
Excuse me, sir. Excuse me, sir.
Hello?
Kindly put your presentation on the presentation mode, sir.
Oh.
Kindly put the slides on the presentation mode.
Presentation board, where would that be?
Slideshow, sir, in the bottom panel, sir.
Bottom panel. You cannot see my shared screen.
It is visible, sir. So kindly click on the icon besides the number 65% below, sir.
Oh, okay. Well, how do I?
Or you can choose F5, sir.
What is that? How do I? Is it?
Sir, could you please click on F5 button on your keypad? F5.
F5. Okay. Okay. Is that better?
Yes,
Can
sir.
you now?
Yes, sir. You can carry on, sir. It's
Oh,
clear.
okay. All right. Yeah. Thank you. Yeah. That is, yeah, there is this old saying about finding something good even in a disaster or a calamity. If there is something like that in this coronavirus pandemic, it is that we have learned to teach our courses remotely using internet and telephone. We have learned to learn, students especially have learned to, have been able to learn using this new method of delivery of instruction. And of course, we have also learned to provide clinical services using the internet and the telephone. So there's the lessons learned in this most unfortunate situation that we are facing now should not be lost on us. I think you should see to it that we are able to continue to use the technology that we have now come to rely on to provide services to our clients, even after the pandemic is over, hopefully sometime in the next few months, with the availability of vaccine and so on, and a better understanding of this epidemic, we may be able to control it. Even then, I think we should continue to use this technology for a variety of reasons. I have listed a few of the reasons here. For instance, right now in India and even in the United States, for that matter, limited access to treatment due to distance and travel. And many people find it difficult to commute, to come to the clinic and get the help that they need. And then there is a limited access to treatment due to the non-availability of speech language pathologists. It is especially true in India that there are clusters where there are quite a few speech language pathologists, and then there are vast areas in India where there may not be a single person providing speech language pathology services. And then if a person doesn't have to travel, doesn't have to take time off from work or from school to come to clinic and so on, if there is a way to deliver this kind of service at home, then probably the attendance and motivation may be better. So it is also something to think about, that many times that a client may not be able to show up at the clinic for this for a variety of reasons. Especially in India, and of course it is true even here in the United States, there is an urban-rural divide. There are better services available in major cities and urban areas, and the rural areas, especially because in the United States, the rural areas are losing population in a big way. And that is true probably in India too. Villages are losing population, and then there is no incentive for professionals to move into those areas to provide service. So it would kind of even out the playing field between urban and rural populations, rural areas. Okay? And then it is also possible that the lower cost for travel and possibly for treatment, many times that if a person has to travel to Bengaluru or Mysuru or say any of the other major cities and then live there for an extended period of time and so on, it is very expensive to do that. And so it may be possible to reduce that barrier to service by lowering the cost of the service. And then, of course, it is if there is a larger pool of clients available because of telepractice, by internet-based, telephone-based practice, then it may be possible to provide more training to our students. And that is also something to keep in mind in that. So if there is a silver lining in this extremely dark sky that we are facing now, it is that we have learned some lessons, and these lessons should not be forgotten once the pandemic is over. Keeping that in mind, what I have done is to try to describe a method of treatment for stuttering in adults and adolescent population. That it is so that we can provide this kind of service. a quick note on terminology that I use. I use the term stuttering to refer to a disorder. So disorder, stuttering is a disorder. And then I use the term stutters to refer to the interruption in the flow of speech, syllable repetition, sound prolongation, cessation of speech, and so on. That actually the symptom, the obvious manifestation of stuttering being an underlying condition, and stutters being the manifest symptoms. And then, of course, people who stutter, of course, have exhibit these kinds of disruptions in flow of speech, syllable repetition, sound prolongations, cessation of speech with certain regularity and in varying durations and with some associated features and so on. So that is just a quick description of the terms that I use. Okay, so when it comes to the treatment for whether it is for children or adults, the treatment is not really based on, especially the behavioral treatment, that is controlling, stuttering, and attempting to speak more fluently. That is what we mean by behavioral treatment of stuttering. It is not based on any kind of theory. It is not really that, in fact, even way back in 1999, Siegel and Gold said that the behavioral treatment does not depend on any theory of stuttering that it attempts to describe the causes of stuttering or the development of stuttering or the persistence of stuttering and so on. And that is the same thing with this one. The program that I'm going to describe is not based on any kind of a theory, but it is a practical one. That is the one that there is some research evidence for it and also clinical evidence for it. So that is based purely heuristic, not based on theory. And that. And about the assumptions that we use is that stuttering in adults and adolescents is a lifelong problem. It is not going to go away. It probably is going to tone down a little in later life, when they are in the 50s or 60s or 70s. So they stutter less. There is some evidence for that, but it is not. It is a lifelong problem that is not going to be. That it is very rare for an adult or an adolescent to completely overcome stuttering. They have to manage it. They have to control it. And then people who stutter, they have many different expectations. But then all of them would like to talk more fluently with fewer stutters. And that is probably that is true, that even those who are saying that I would like to talk openly and I don't want to hide my stuttering and I would like to not use techniques to hide my stuttering or manage my stuttering. Even those people would like to speak more fluently or with fewer stutters. In general, that is in fact fairly obvious that that is the case. And although that the program that I'm going to describe is not based on any kind of theory about causation and so on, we generally accept that it is stuttering is a neuromotor disorder. It is not, many people who stutter have anxiety problems. They have social anxiety, but then social anxiety is the result of stuttering rather than the cause of stuttering. So we would think that although we do not know exactly what the neuromotor problem is, and there are many explanations and speculations about it, we would think that it is based in, it's the brain based, and brain, part of the brain that is responsible for the movement of speech structures that is causing stuttering. That is, and it is not based, it is not because of upbringing, parental upbringing or anxiety or any kind, all of those things. All of those things may have some implications for how the persistence of stuttering or the development of stuttering, but it is not the original cause of stuttering. So that's probably is fairly generally accepted. Okay? And so if we want people, adults and adolescent people who stutter to speak more fluently, the only way that can happen is if they make some changes in their speech. So it's a neuromotor problem, and they have to learn some new neuromotor skills. So they have to speak a little bit differently. And that is what we will talk a little bit more about in the next few slides. And now, this is, oops, sorry. One of the very strange, there are many strange things about stuttering, as you know. It's a strange disorder in the sense that you can make stuttering disappear almost instantaneously by doing a number of different things, whether it is a DAF or masking noise or syllable time speech or a variety of other things. So they do that. One such thing that is remarkably effective in controlling stuttering is what is called RCS, response contingent stimulation. And people have done, there are extensive reviews of it. You can read about it. People have done a variety of things. So they, of course, people have used the electric shock, which is not obviously recommended, and probably will not be used today. In the past, they have used it, or they have used masking noise. They have used things like stop, or even in a couple of studies, people actually said good. A clinician or a researcher would say good every time a person stutters, and the result is it is totally unexpected. They would actually reduce the number of stutters rather than increase it. By saying good, it is not a positive reinforcement. It actually serves more like, oh, I'm stuttering. I need to do something to make, to speak more fluently. So it just calls attention to stuttering, stutters, and therefore it reduces it. So in fact, in one study, they used a neutral stimulus, every time the person stuttered, they said tree, every time. Stuttering went down, stutters went down. So that is the that is what we mean by RCS. RCS simply means that there is a stimulation. A stimulation can be anything. It could be a masking noise or a tree or good or bad or anything like that. Immediately after a person stutters. And the result almost always, is, with a few exceptions, is that there is a significant, sometimes a dramatic decrease in the frequency of stutters. Okay? One of the things that has been tried, if in a form of RCS, is a time out from talking. We all know about timeout. We do that with our children sometimes. You say, go to your room and stay there for 10 minutes if they don't behave properly, so or as expected, and things like that. So timeout, and here it is timeout from talking. So every time a person stutters, they have to stop for a variable period of time, maybe 1 second, 2 seconds, 5 seconds, 10 seconds, like that. And then they resume talking. So timeout from talking is simply just stop when they hit it is a stutter, and then wait for a variable amount of time, and then start again, start talking again. And that is what is called timeout from talking. And timeout from talking, there are a huge number of studies, and I've only listed a few of them here. And they go back to 30, 40 years, is that from 70 to 100% reduction in stutters in most children and adults. So TO is very effective in reducing stutters, and in a moment we'll see that there is a variation of it, that it is also very effective. And in fact, many programs, regulated breathing, which is a modified breathing that is used for whenever a person stutters, they stop and then take a breath and then talk again and so on. That kind of treatment is a form of TO. And the well-known LIDCOM program for very young children is also it uses a form of TO, a benign form of TO. They say, oh, take it easy, slow down, or stop, or, let us have a smooth speech. Various different ways of, in a benign way of saying, hold on, slow down, and talk. That is there as well. And the timeout from talking, TO, has been used clinically. In fact, in one large study, there were 30 adults, and they were able to reduce their stutters down to, a reduction of almost 81%, in a majority of the people who stuttered, and other that. So one advantage of TO is, in a moment we will see that there are other ways of controlling stuttering, but all of those other ways actually alter the naturalness of speech and their rate of speech. Unlike that, TO actually increases the rate of speech. It does not decrease the rate of speech. And therefore, it does not affect naturalness as much as other forms of inducing fluency in people who stutter. Implementation of RCTO, effective and simple for young children, older children, adolescents, and adults. All you have to do is somehow give them a signal. A signal could be as simple as this one. Oops, here. Nope. I thought that I had a tone. I had a tone here, but it is not playing. So it could be just a tone, and you could use a whistle or something like that, and just say that, and all you have to do is somehow highlight a stutter occurred, and you need to stop for a fixed amount of time. That's all you need to do, and so it can be used with adults and adolescents and older children, and even with very young children, as we pointed out in the LIDCOM program. Okay, contingency is important. That is the most critical part. In fact, there have been a number of studies done, and what it shows is it has to be the stimulus that follows a stutter must occur immediately when the stutter occurs. Okay, there should not be a time lapse. So as soon as you hear a person, at the first moments of stutter, immediately, then you need to signal, oh, you need to stop, okay? And then for a certain amount of time. So contingency is very critical. Nothing else, as we'll see in a moment, is as critical as that. That is the most important part of TO, is that it is at the first hint of stuttering, a stutter, it should be a signal to stop from talking, and then resume talking after a certain amount of time. Okay? Speech rate and naturalness are unaffected. In fact, there have been studies done on that, and it all shows that speech rate is actually increases rather than decreases in the TO conditions. Okay? And the most interesting thing about TO is that self-administration is as effective as clinician-administered timeout. That means if the person recognizes that he or she is going to stutter, and then immediately stops for a certain amount of time, and then resumes, self-administered, there is no external stimulus. It comes from within, and that self-administration that is called the SADO is also very effective. And not only it is effective even if it is not done in a consistent fashion. It doesn't have to be 100% of the time. The person who administers this to himself or herself does not have to be totally accurate. They can miss a few stutters. In fact, in some studies, as few as 50% of the time, if they are accurate, there is a significant reduction in stutters. So it is the self-administration, that is the critical part. So, if you can start with the timeout, administered by the clinician, and then immediately transition to self-administered timeout, and then just keep a close, make sure that the person is doing it correctly, stopping immediately, and then resuming after a certain amount of time, and so on. As long as that is done, then this self-administered timeout is very effective, and it is tolerated. Although, way back, it started as though it was a kind of a punishment. People thought that response contingent stimulation is a form of punishment. That came because of the earlier studies that used loud noises or electric shock and things like that. But as we know, it doesn't have to be that. All it is you highlight stutters. That is all you have to do. And it is tolerated well. People do not think that it is a punishment, or it is something negative, or it does not distress them. It doesn't produce anxiety in them, and so on. So there is no evidence of that at all. Okay? And the timeout does not have to be very long. Although people have used timeout of 3, 4, 5 seconds sometimes, it doesn't have to be. All it is stop, start. Just 1 second is good enough. Okay, so timeout is a very good treatment technique. And the important thing about this is this can be easily taught even in a telepractice situation. In fact, ideally, probably that you should use a video connection between the client and the clinician, but it doesn't have to be that way. It can be just an audio connection as long as you can hear it, and then initially you can train the person to with the TO, and then train the person to administer TO by themselves. That is all you need. There is no need to do that. So this is something that can be easily done in a telepractice situation. It is not a very difficult skill to master. And that is the attraction of using timeout, because we are looking for something that can be taught when the person is not sitting in front of you. So that's the most important thing about that. So only thing about TO that is not so good is that for a small number of, well, I don't know if it is a small number, maybe about 40% or so people, it may not produce a significant reduction in stutters. In about 60, 70%, it does. In 30, 40%, it does not produce a significant reduction in stutters. And that is especially true in adolescents and adults. In fact, it is much more effective in very young children than in adults and adolescent children, adolescents and adults. So so it may not be entirely sufficient. So you may need to do something else in addition to TO. So what I'm suggesting is whether it is in person or in a telepractice situation, make sure that you employ timeout. It is a very effective a procedure, a simple procedure, and I think that it would be helpful to most people, although it may be helpful to some people to a greater degree than for others, but it is helpful to everybody who stutters. Okay? What is the alternative? What else can be done in addition to? It is not a question of. So we will in the outline of therapy, the treatment that I'm suggesting here is always uses timeout. That is one of the central techniques. But then, if it is not sufficient to control stutters, then what else can be done? One of them is what is called smooth speech. In fact, it is, I have one reference for it here, but there are other examples of smooth speech. Smooth speech is not is actually a variation of what is called prolonged speech. And if you have worked with people who stutter, more likely than not, you have used some form of prolonged speech. And the only difference between prolonged speech and smooth speech is, in smooth speech, you do not really target a rate. In the prolonged speech technique, well, in fact, if you do it right, you do it the way that it is suggested in the literature, you start out with a rate of 20 to 30 syllables. So in prolonged speech, for instance, you would say, Badu, I'm using this Kannada site, one just to be to show that it can be used with, it doesn't have to be in English, it can be in local languages. So in prolonged speech, for instance, initially at least, you might start with Badu Kinali Ananda Vemukya Badu Kinamula Udesha Ve Anandada Shashvata Santushada Hudukata, and so on. But that is not necessary. I mean, in prolonged speech, you destroy the speech pattern of the person who you are treating, and then rebuild it. That's a long process, and it is not a very well understood process. In fact, personally, I have found it very difficult to do that. This part is very easy. To teach someone to speak at a 20, 30, or 40 syllables per minute is easy. But then what do you do next? You have to gradually increase the rate to 60, 70, 100, 120, 140, 180. That is a daunting task. It is a very difficult one to teach, and it is a difficult one to master for our clients. So prolonged speech is a very difficult one, but smooth speech, on the other hand, all it does is you use a slightly aspirated, a breathy speech. Bhadukinali ananda ve mukhya, Bhadukina mula uddesha ve ananda shashvata santoshada hurukata. It does reduce the rate a little bit, but it can be easily, ಬದುಕಿನಲ್ಲಿ ಆನಂದವೇ ಮುಖ್ಯ ಬದುಕಿನ ಮೂಲ ಉದ್ದೇಶವೇ ಆನಂದದ ಶಾಶ್ವತ ಸಂತೋಷದ ಹುಡುಕಾಟ. So you can reduce the amount of the breathiness and increase the rate fairly quickly. And then one other thing that what I do is I do not use this smooth speech or the one that next technique I'm going to talk about, the syllable time speech, throughout. Only when there is a timeout, when you restart the speech, you use it for one or two words. So, particularly, if many times it is hard for a person to produce the first word in a sentence. So if the person goes particularly, as soon as stop, and then particularly, just use a breathy voice, and that helps increase the fluency or reduce the stutters and that. So it is not necessary to use it consistently and all of the way, all the time that a person talks, but only after a timeout. And when they restart the speech, they start it with smooth, a breathy speech pattern, and that is all. And for one or two words, or maybe depending on what the severity of it is, if it is necessary, maybe for the whole sentence, the following sentence, it could be used. But it is not necessary to use it all the time. Okay? And the same is true of syllable time speech. And this is I used these two slides. This one, you can use if you are using a telepractice, you can use yesterday's newspaper as long as the other person also has the same newspaper in his or her hands. So you could, in fact, I took it from from Prajavani newspaper. So it is, as long as you have the same newspapers, you can use that in your telepractice, or you can have a collage of these pictures. Again, it can be used swinging, talking, reading, jumping, and so on. Or you can use the other technique that can be used is syllable time speech, and that is also very easy to use, easy to teach a person to do. So you say sliding, reading, kicking, okay? And then of course you could increase the complexity of it and say, the man on the bench is reading the newspaper, okay? One syllable at a time. So that is what syllable time speech is. Once again, both of these, whether it is a smooth speech or syllable time speech, it is used only after a timeout. So timeout is the basic technique, and the syllable time speech and or the smooth speech, one or the other, not both, is an add-on to it if that is found necessary. Okay, so that schedule, that is another thing that what I have found is once a week is not going to do it. See, that is what we mean by learning a new neuromotor skill. Okay? You cannot do that if you do that once a week. You have to do that preferably 4 or 5 days a week. And this can be done if it is a telepractice. Many clients would find it very difficult to come to the clinic 4 or 5 times a week. But if it is done over the telephone or the internet or the computer or tablet, then it is possible to do that. So 4 to 6 weeks, 4 days a week would be a good ideal schedule. More could be in-person, remote, or preferably hybrid. Okay, maybe once a week, the person comes to the clinic. The 3 times a week, it is over the telephone or using WhatsApp, video or audio. That can be done. And then the technique would be RCTO plus either syllable time speech or smooth speech as necessary. If RCTO alone works well, by all means, just use just RCTO. That is a self-administered timeout. That form of RCTO. We're talking response contingent stimuli timeout, and here it is a variation of that is the self-administered timeout. So that is the technique. If it works, that is fine. Treatment session. One thing that I don't do is give long explanations. Instead, I use only modeling. I model what the person has to do. No point in explaining things. You show them, not explain them. Okay? And then, of course, shaping, reading, and monologue and conversation. All of that can be done in a single session, and you should be done in every session. That it is not you start with reading, and once they become completely fluent in reading, you go to monologue and then conversation. No, it is all of those things, and then the stabilization, that is doing more of the same things to make sure that they do that, and then general. That is another thing that often in stuttering therapy. What we do is we wait until the therapy is completed in order to start with the generalization and maintenance. No, you should encourage from the very first day that for the person to use self-administered TO and other kind of and of course, syllable time speech or the smooth speech if necessary. So all of that has to be, it should be throughout. Every session should be like that. We are running out of time here, so I'll go through it very quickly. I would use this unhelpful thoughts and beliefs of stuttering scale at the beginning of the therapy regimen and at the end of it. And if you do that, you can probably, it is not so much important to know how many times they stuttered or how long they stuttered and all of that. Instead, it should be just, how they feel about it. The success of therapy should be based on how they feel about stuttering and the therapy that they received, rather than about quantifying the rate of speech or rate of stutters. Okay? At the beginning of each session, I would ask a person, what did you do? How did you do yesterday? Or how did you do, if it is 2 days ago, 2 days ago. So in terms of stuttering severity, anxiety level, fluency scale, how much did you use smooth speech or syllable time speech? And then of course, how many times you were able to use self-administered timeout. So every session begins with a report by the client about what they did outside of their session in that. So that is Matt. And that is about it. So I think we're here at on the hour there. So if you have any questions, you can probably communicate with me. But other than that, thank you very much. I appreciate the opportunity to make this presentation today. Thank you, Dr. Nataraj and Dr. Sanjana and Dr. Nasiman. Thank you all for your invitation and the opportunity to make this presentation today.
Thank you very much, sir. It was a wonderful presentation, and a big thank you for having the specific techniques demonstrated on a real-time basis. It was indeed very informative. So I think Ratna sir would like to speak something here. He has raised his hand. If Ratna sir can unmute himself.
Well, no, I just want to thank and congratulate Venkatgiri on such a beautiful, clear demonstration of the therapy that he's been using and the effectiveness of it. Congratulations. Thank you.
Thank you.
So Nataraj sir would want to speak here also.
I'm sorry, Dr. Venkatgiri. I mean, just, yeah. Thank you very much, and for accepting our invitation and taking part in this webinar. Of course,
Thank you.
I will continue to discuss with you about the timeout, because we have done some work on time work as highlighting. I mean, I think timeout is considered as highlighting. So
Yeah, exactly
we had
right.
done some work on that. Maybe I will be able to discuss with you later. I will do that. Anyhow, yeah.
Thank you.
Yeah, thank you very much for this one. Over to Sanjana.
Yes, sir. Thank you, sir. So on behalf of JSS Institute of Speech and Hearing, I request you to kindly accept this letter of appreciation for serving as the resource person in today's webinar, sir.
Thank you. Yeah, appreciate that.
Thank you very much for joining us today, sir.
Yeah.
So can we begin the next session, sir? Nataraj?
Welcome to Dr. Yamini. Thank you for taking part in the webinar. I welcome you. Over to Sanjana. Ms.
Thank you,
Thank
sir.
you very much, sir. Thank you very much.
I extend a warm welcome to one and all to the session 3 of the day 6 of the webinar series. We have with us today Dr. Yamini BK, who will be addressing the topic Clinical Management of Dysarthria. Dr. Yamini is currently serving as the Additional Professor, National Institute of Mental Health and Neurosciences, Bangalore. She has delivered over 30 invited talks at national forums. She has conducted 2 to 5 day workshops in the area of dysarthria and dysphagia both at national and international levels. She is a recognized guide to PhD students, and she has also been recognized as a co-guide for PhD candidates. She's been involved in guiding PG students as well. As a principal investigator, she has completed various research projects, and some of them include articulatory kinematics in amyotrophic lateral sclerosis, acoustic analysis, perceptual judgment, and algorithm-based automatic classification of vocal tremor, and so on. She has also served as a co-investigator for various research projects. She has won the Best Poster Award in ARPAN 2019 for the topic on mastication in patients with ALS, a pilot study. She has several national as well as international publications to her credit. She has been involved in a publishing and she is also serving as a peer reviewer for various articles and conference proceedings. With this note, I welcome Dr. Yamini to the current session and may now request you to kindly take over the session now.
Thank you very much.
Ma'am, am I audible?
Yeah, you're audible. Yes. Am I audible?
Yes, ma'am, you are audible too.
Okay, all right. Yes. At the outset, I would like to thank Dr. Natraj, Head of Department of JSS Institute of Speech and Hearing, for giving me this opportunity to speak here. I also thank the entire team, Dr. Narasimhan, Sanjana, and all who have supported this and who are making it a big success. Yes, so I will start this topic. Can I start the screen share?
Yes, ma'am, sure, ma'am.
Can you see my screen?
No, ma'am. No, ma'am.
Just a minute.
Yes, ma'am. Now it is started to screen share. Slides are visible, ma'am.
I'm not able to go on now. Okay, I need to.
You can put it on slideshow mode, ma'am.
It's not going on slideshow now.
You can press F5, ma'am, alternatively.
Okay, now it's now?
Yes, ma'am. Yes, ma'am, it is visible.
Okay, thank you. Okay. So this topic, which is clinical management of dysarthria. Yes, now if you see by most of the clinics, whether it is a hospital-based or in the clinics, I am sure there are a lot of people who will be carrying this out in order to achieve efficiency or the best performance or in order to elicit best performance from the patient with dysarthria. So I will be talking a lot on the management of dysarthria rather than on dysarthria, but just a brief introduction before that. So we know that speech is a very important mode of communication, more so during this pandemic, right? And we also have started using tele-mode, so tele-rehabilitation, tele-evaluation. So speech seems to be a very important communication mode for us. Now, it is a communication mode for the clinician, yes, but it is also a communication mode for in general. So now, coming to specifically dysarthria, let us read from bottom to the top. Now, there are various reasons why this speech can be affected. You could have vascular reasons. There could be a trauma. There could have been a degenerative condition. There could be an infective cause. Someone had fever and sometime later they developed, some kind of a speech disturbance. There could be toxic conditions, manganese toxicity. So that can happen, or there could have been a tumor somewhere. So all these which disrupt. Let us go to the line above and say that the strength, the speed, the range, the steadiness, the tone, and the accuracy of the muscles involved in speech production tend to be affected. So which are these? They are nothing but, the respiratory, the phonatory, the resonatory, the articulatory, and the prosodic aspects of speech. So all this, once it is affected, which leads to a difficulty in production of, or what you call as a control of, a good control in production of speech or executing the speech task. And because of a neurological cause, we use the term dysarthria. So you can see that there seems to be a lot of factors before we actually say, okay, the person seems to have dysarthria. So there are different types of dysarthria, as you know, that classification is also there. You have the unilateral UMN dysarthria, the bilateral UMN dysarthria, then you can have, or the spastic dysarthria. You can have ataxic dysarthria, you can have flaccid, you can have hypokinetic, hyperkinetic, mixed dysarthria. These are all the types of dysarthrias that one talks of. Now, coming to look at, I'm going to present this not based on the types of dysarthria, but from a different perspective. So now let us look at vascular etiology as a cause of dysarthria. So you will find that, a disruption anywhere, either the cranial nerve or the spinal nerve, or it could be bilateral upper motor neurons, the cerebellar circuits, the basal ganglia circuits, or it could be unilateral upper motor neurons. So any of these, if in them the blood supply gets affected, we know that there could be a possible stroke. So you will be surprised to know that 92% of the stroke lead to unilateral UMN dysarthria. Very often this is written as spastic dysarthria by everybody, but it would be ideal for us to write it as unilateral UMN dysarthria. And then you can see that the 17% can have bilateral UMN type, then 11% will have a cerebellar circuit, so that causes ataxic dysarthria, then 9% can have flaccid dysarthria, 4% hypokinetic, 1% again, hyperkinetic. So you can see that unilateral UMN type of dysarthria seems to be the most common occurrence following a stroke. Now let me give you a case illustration here. This is an adult who had a sudden onset of right-sided weakness and slurring of speech and a few other symptoms. So CT of the brain showed that it is the left internal capsule, the posterior limb, that was affected. So how is the speech characteristics? Yes, it is important for us to know. Before I start with management, one of the first things I need to know is to get a detailed history, right? What had happened? Did it happen? Was it, just a few days back? That is, was it acute? Was it long term? So was it chronic? And a few years ago that it happened, few months ago it happened. So what have we collected? And then we also know that we have to diagnose dysarthria and then proceed with the dysarthria management. So in this case, he had imprecise articulation, some harsh voice quality. Now, what would ideally be, if you take the subsystems of the speech, and you would say, okay, I would be working at two important issues on two important systems, that is the laryngeal as well as the articulatory. But very often in these cases, you will also find that their respiratory subsystem gets affected. So there will be a mild involvement. So if you do a maximum phonation duration, you would find that they may not be more than 4 seconds, or it could be extremely restricted. So that means I would suggest that focus on all the subsystems of speech. So focus on the respiratory subsystem, wherein you will ensure that there is adequate breath support for speech. So either you start with just breathing exercise, or you use a breathing phonatory combination and improve the respiratory support so that there is a consistent alveolar air pressure available for speech. So improving that and then using the non-speech exercises, as well as then we can focus on speech. So you know that it is a very graded method in which we need to look at, or we need to work with dysarthria in dysarthria cases. So, and then we go on to improving articulation. So what do? There are traditional approaches. So you give them a feedback. So ask them to precisely come out with the utterance. So does the non-speech exercise support this, oromotor movement, and hence, you have better elevation of the tongue, better, posterior, whether it's anterior elevation or a posterior elevation of the tongue. Is that possible? So all that can be stimulated, and then, we can focus on speech. And if it is a mild involvement, then you know that we also look not only at articulation, but also on the prosodic aspects of speech. So how is the rate of speech, the number of words that you can say in an utterance, the tonal patterns in speech, all this. The most important is how frequently can we conduct these sessions? So are these sessions, if the patient is still in the ward, it may be possible for us to call them every day. You have a session and then give them, continue to work on these things even at home. So you have a home training program. So is that possible? Or if this patient, just comes for a visit, from a few kilometers away, so how frequently would you space the session? But now, given that, there is a lot of tele-rehab that is taken up, it's taken a big stride, I would say. I think people can hold a lot of sessions frequently to improve the dysarthric, to reduce the dysarthric component and improve the speech overall. So this is one aspect. Now, what about this person who had a left aneurysm? So very often you find that we diagnosed him as a case of unilateral UMN dysarthria, yes, where he had a lower facial, weakness. So if you ask him to smile, or, some kind of, actually he had a global aphasia. So where is the question of he comprehending anything to bring about a response? So we would assess during his other tasks, like whether when he was yawning or when he was trying to take something to drink. So, or, he would on his own, kind of, spread his lips. So using these other methods, when we assess, some of the time they do understand some pragmatic commands, although they are aphasic. So if you tell them, open your mouth and put your tongue out repeatedly, when it happens, they understand, because we ask them to do that almost every day. So they seem to understand. So that comprehension is preserved. We are able to diagnose this unilateral UMN dysarthria. But the question is, can I immediately start intervention with him? The answer is no, because I need to handle the global aphasia component in him, improve his comprehension before I can actually target the dysarthric component. But passively, we can do a lot of things. So passively, we can, you can use a lot of, if it is going to be a lip retraction which is affected, you can use a passive stretch. If the labial, the lingual movement is affected, you can use some kind of a, not a metal device, but something like, a plastic spatula, and then you can just move the tongue. So in other words, during the process of maintaining oral hygiene, you are tackling some of these movements passively, but you will not be able to address, the dysarthric component initially. So in this case, what happened was, it was almost after an year that we actually started working on this dysarthric component. The other thing is, they will have a lot of drooling. So that needs to be taken care of. So the dysphagia component and the aphasia component come in the way before we can actually manage the aphasia and the dysphagia component come in the way before we can actually manage the dysarthria. So it takes a little back seat, but nevertheless, it does come in the picture. So now I went through the literature to see, for the last few years, what are the dysarthric management strategies available for post-stroke cases. So you can see that I have listed in the recent article, they talk about some 23 strategies which are available. So it is important for us to judicially check and apply these strategies. Now, for example, if the resonance is going to be affected, then you know that if this is going to be a non-progressive condition, you can suggest for a palatal lift prosthesis. Otherwise, you may not be able to. So now let us say that in conditions where a person had a stroke initially, developed dysarthria, and then he had another recurrent stroke, and after the first stroke, the dysarthric component had not resolved completely, but after the second stroke, he had developed aphasia component also. So now you can see that applying any of just the dysarthria management strategies is not as easy as one thinks, though a whole lot of these are available. Now, coming to Be Clear, that's one of the recent strategies that you can see. Then constraint-induced dysarthria therapy is also a very recent strategy that you can see. Be Clear is another one. Now, what we do in Be Clear, what happens is you're trying to tell them that, look, I do not hear you, I do not understand you. So when you give such prompts to them, if their comprehension, their cognition is adequate, they may be able to produce a better articulatory posture so that the articulatory precision is much better subsequently with the trials. So it requires a lot of training, home training, all that. So this is available and people can use depending upon what subsystem is affected, what is the type of dysarthria, though it is a post-stroke dysarthria. Now, suppose in a post-stroke dysarthria, you have predominant what is called as the dystonic component, then just the oromotor exercise may not help. So you may have to give them some kind of a feedback approach in enhancing this, or improving the dysarthric component in them. Now, suppose somebody develops some kind of a thalamic bleed leading to some kind of a hypophonia as a component of dysarthria in them. So here you can suggest not vocal exercises, and you can also suggest singing, okay, as well as speech therapy. So there are strategies. So you can use, otherwise you can use Lee Silverman voice technique, and then you can use learning based speech therapy. So all these are available. Now, how much of this, how much is this going to benefit the patient actually? That depends upon what is the requirement from the side of the patient. Does he require to get back to a job? That is required. So the motivation is very important. So getting back to a job which requires him to speak more will motivate him to use the strategies that we suggest to improve dysarthria. So otherwise, if he is not on a job, he's okay, retired at home, but still wants to remain very active, socially, then again it becomes important. But otherwise, if he's not, then he may not be motivated to use the strategy, although we may insist on any of these. So the dysarthria management must be viewed from a very multi-pronged approach. Infective. So here what happened was, a week before the dysarthric onset, the person had some fever. It kind of resolved, and subsequently he started developing problem only with speech and not with limb issue. So here he said the tongue was not cooperative and it was withdrawing during speech and was easy to talk while speaking. So look at the history. So it's important to get the history, have it on record for us, go through it so that we can administer the right kind of evaluation and subsequently the management strategy. So based on his inputs and based on the evaluations, we diagnose this case as a case of moderate hyperkinetic dysarthria due to oromandibular dystonia. Now, when we kind of teased out, the evaluation procedure to see which is the subsystem that was involved more, so you could see that there is distortions of the jaw, lip, as well as the tongue, more during speech than during a non-speech task. So all this lead to a diagnosis as well as determining the dysarthria management. And you know that in these cases, sensory tricks work with them. Now, this sensory trick is very often, if they are cognitively very alert, they start realizing this. So what he started doing was to use have a chocolate in the mouth and then speak. Now, this was also evaluated in the session. So management of dysarthria will require not only to review records and have a first line of evaluation, but also we need to evaluate that if we apply a particular strategy, does it give out any effect, immediate effect, or we have to wait for a long-term effect. So in sensory tricks, you know that the effect is going to be immediate, and we found that very clearly, perceptually, there was definitely an improvement in his speech. It improved by, the intelligibility was better by about 20%, though it was not, it did not sustain enough. Now, what happens with the sensory trick of chocolate is that in his case, he would start salivating. So when that happened, then he had to swallow more time. So again, the intelligibility was getting affected. So what we try to do is not, if you look at literature, there are various sensory tricks available. So you can use a tactile feedback, or you can use a proprioceptive feedback. So wherein, you can touch the jaw, you can touch the cheek, to provide, improvement in dystonias, oromandibular dystonias, to improve their intelligibility. And these are some of the tricks that can be used. But apart from that, there is also feedback that we can give them. So what we did was to use the selfie mode of the camera, or put him in front of a laptop with a camera, give him a feedback on what was that extra movement that was happening. So when that feedback was given, he took a while before he started, responding to that. So which means that trials are very important. So just one shot sometimes does not help. Sensory tricks, yes, we realize that yes, improvement in intelligibility was immediate. But then what about the second strategy, that is visual feedback? We found that we had to do repeated trials before he could comprehend the concept of, monitoring his oral mechanism during speech. So that was the thing. So we did suggest these, and of course he was lost to follow up, and we didn't continue, we don't have a feedback. But well, in general, with oromandibular dystonia, we have found people using sensory tricks, and they find it very useful. Now, having a chocolate is not very healthy thing. So what is the alternative that one can suggest? Now, not like stuttering, where they used to keep a stone in the mouth, and then, that would be incorrect, and it would be very risky. So what is the alternative would be, using some kind of a stick that kind of protrudes outside. So that way the risk of swallowing is not there, but still there is some sensory information that is provided so that the speech can be improved. Yes, so but it is I think a lot more studies need to be done. Long-term studies need to be done on how these sensory tricks can actually help in getting the person, or how the sensory tricks can help the person, speak effectively in the society. So that's the take home. So we know that sensory tricks are basically postural adjustments to reduce the adventitious movement that is visible, as I said, and it has tactile mechanism and proprioceptive or kinesthetic feedback. So you can use any of these, and they do help. What is important is we need to have an ear to note that difference. That sometimes there are conditions when they have been situations where the patient says that yes, I am able to make out the difference, can't you? So that means it is the sense that the clinician sensitivity that matters a lot. So the clinical exposure, the clinical sensitivity, the clinical acumen that we have, that matter a lot when we talk of, okay, judging, saying that yes, there is an improvement, no, there is no improvement in the speech. So now coming to this condition, we are all very familiar. We know that there are a lot of them, for reasons unknown, they do develop spasmodic dysphonia. So there is a strange strangled voice. So the laryngeal system is more affected, and you have different types. You have the adductor spasmodic dysphonia as well as the abductor type of spasmodic dysphonia. So in these cases, again, it is very, very difficult. Managing is not very easy. Now, it is only in the mild cases that we are able to manage, but in the moderate and severe, we are not able to do. So what do we do? Now, there are some people, literature talks about increasing the vocal pitch. Now, I did try increasing the vocal pitch, but let me tell you, that did not solve the problem because there is no transfer of this. He's okay with raising the pitch for some time, but are we not creating a vocal abuse to the person? So that is where it is. So it stops. So there is a full stop to it. Using a breathy voice. So again, we are kind of abusing the vocal system. That is intact. Otherwise, it is only during speech that such a strain component is observed. So that way, there is no effective behavioral strategy to improve spasmodic dysphonia. Some of course, we can tell them to use breathing, a little bit of prolongation in speech. Maybe it will help. It may not help most of the time. Okay. Now, there's another Botox treatment that is available. So we know that immediate post-Botox, patients with spasmodic dysphonia do improve, their quality of, voice improves. The strangle component is not there. They are able to come out with a relatively good, laryngeal quality of speech. So in that case, what is the role of ASLP that comes into the picture? So voice conservation is a very important issue. So you can talk to them about vocal hygiene, voice conservation, and so forth. We know that it is only with repeated Botox that there's an improvement in voice quality. So this is one, the abductor type. They suggest a hard glottal attack again. So here again, it is just not possible. Hard glottal attack, you continue to do that for a whole month, and then you will be the one who develop even a vocal nodule in the process. So we are creating a problem. So is this possible? Is treatment for spasmodic dysphonia possible under supervision, stringent supervision? We don't know. So that needs to be tried and worked out. Only then the behavioral management in this condition can be looked at. So what about in patients with vocal tremor? So is there a management strategy? Now, why does someone develop an essential vocal tremor? So does the patient, is there a family history of vocal tremor, or is there, it is a sporadic case. He has just developed vocal tremor. So, and now this again, the management is a huge question. So all these conditions which come under hyperkinetic dysarthria are more often treated pharmacologically rather than behaviorally. So when you talk of pharmacology here in vocal tremor, again, it is not beneficial at all, I would say. So vocal tremor is another condition where we find it very difficult to manage, the component, the hyperkinetic component in that. So let's go to this condition where there is a neurodegeneration of the system, and that happens in Parkinson's disease, and that leads to dysarthria. And so what are we looking at in management of dysarthria? So as usual, we need to classify what is the type, of Parkinson's disease. It is a mild condition. Is it a moderate condition? Is it an advanced condition? Is the person on medication? Has the person had deep brain stimulation? What's happening? What is the history of the case? So we look at that before we address the issue of the management. Now, there are possibilities that he would have been seen by someone 6 months ago, and then now there are variations in which, people come to seek, the clinical services of a speech language pathologist. So they may come immediately, they may come a bit later, they may come 2 years later. So we do not know when they come, but they may reach us for the reasons that the speech is affected. There is a dysarthria component in them. So what do you find? You find hypophonia as a glaring feature in them. In some of them, you find palilalia component. You have in other words, you have short rushes of speech. Then you have rigidity in the system. You do not find the articulators, they do not, the range of movement of the articulators is not enough. And if you ask them to do a DDK, it is so rapid, and they are able to do, you put the ear close to them, and then you are able to make out, that yes, he is able to produce all the sounds, but at such a rapid rate. And these are not, these are very typical features of Parkinson's disease, or dysarthric features of Parkinson's disease, which come under the diagnosis of hypokinetic dysarthria. Now, so when such a thing happens, so for the alertness in the session, because, having a drug and he comes to the session, is he drowsy? He's had some kind of, he has some emotional issues, so he's not alert in the session. So there can be a lot of comorbidities that one needs to look at before we look at, managing dysarthria in the patient. So then we say whether the patient is stimulable. So what do? We need to increase the strength and endurance of each of the subsystems of speech, right? If you ask them to do, can you phonate for a long time? They'll phonate for 3 seconds or 7 seconds and then they stop. Then you ask them to do this, frication duration, again, it is for a very short time. So all these, wherever there is going to be what is called as airflow management, which is a prerequisite. So that needs to be worked. And then the loudness component, the laryngeal subsystem needs to be worked. And then comes the articulatory precision that comes. So you know that this is the basic principle in Dysarthria management. So if we do not follow this, that means we are only projecting voice from or speech from a very superficial level. And that is not at all effective, I would say. So that is one. So you need to increase the strength and endurance. There are, again, plenty of techniques available. There in the literature, it talks about definitely the rate control therapy, using pacing boards, or you can use the expiratory muscle strength training. So that is also tool is available recently. Then you have the Lee Silverman voice technique, for placement of a voice. You have LSVT loud, LSVT crowd. So crowd is basically a group therapy that is added on. So all these techniques are available, and not to miss is the speech pipe that is there. So where some component of the Lombard effect is basically used here. There's a noise that is introduced, and these are the recently available techniques for us to improve the quality of voice. So, so with this, we go on to what is happening at the department itself. So what we use is definitely, as I said earlier, it is important to have the right posture in order to bring about good, what you call as sustained airflow. So the alveolar air pressure can be sustained well only when we bring about a good airflow. Now, do we have respiratory prosthesis for it? Not required in this case very often. We can use basically some kind of a support. So if you put them in, support in the sense, I would say some of them phonate better or louder in supine position than in an upright position. So you put them on a cot and you ask them to phonate, they are doing much better. So they have a feedback of how this, loudness changes there, how they are able to expire more easily, and so that overall it will improve their speech output. So the breathing exercise becomes very, very essential. So here what we do is even we can use the Anuloma Viloma. We have a lot of strategies in the backyard, yogic asanas, yogic breathing strategies are there. So that can improve the breathing. But what is important is that we need to see that they have a lot of rigidity. So what is the protocol that you can use to improve the breath support for speech? So a simple thing would be, just an upright position, Anuloma Viloma, Nadi should be, that can be used in them. Then apart from that, you can use the exhale, prolong the production of the vowels. So that also can be done. We can use from our backyard, we have the Om chant that is readily available. So that can be used. So then comes the loudness. So how do we improve the loudness? We can either use, suppose in the clinics, most of us have instruments which give us information on the intensity level. So yes, we can use those programs, the therapy programs, in order to improve the loudness in them. Then it is important to improve the prosody. So we know that in all of them, you have monotone that can be there. So can we not use, most of us sing various songs or hum various songs. So can we not sing 4 random notes? All of us as speech language pathologists have measured these singing notes, and you know that they vary in frequency. So can we not ask them to use this? So we definitely ask them to use 3 or 4 notes. So again, we must consider that they may have bowing of the vocal folds, they may have rigidity in the laryngeal system. So all these have to be considered when we administer any of these strategies. And then definitely the rate control that is also required for them. So each of the subsystems of speech is taken care of, and then it is possible for us to provide the Dysarthria management strategy. The most important is, again, how frequent are we doing it? Are we asking them to perform at home, or are they coming to the session every day? So the frequency of the sessions is a very important issue when we talk of Dysarthria management. Just a minute, I'm not able to go to the next slide. Can you hear me?
Yes, ma'am. Yes, ma'am.
Okay, okay.
Ma'am, you can stop sharing the screen and again start sharing now.
Okay. Yeah, now can you see?
No, ma'am, your presentation is not visible.
Yeah, just wait.
It is, yes, ma'am. It is visible now.
Yeah, I'll just put it on slide.
Yes, ma'am.
Make it full screen, please.
Yes, okay.
Slide mode.
Yes, so now can you see
Thank you.
slideshow?
Right. We're
Yes,
getting
ma'am.
it.
Okay, thank you. So we move from, yeah. Yes, so Parkinson, going back to this hypokinetic dysarthria in Parkinson's disease, I would like to add one more thing here. So recently, we had a patient with, who came following the deep brain stimulation and who was referred for an evaluation. So in her case, what happened was, when we did an evaluation, the only abnormality in speech was that the sustained phonation had a tremor component. So in that case, what do? Are you going to do any kind of a management, or you don't do a management? You see a lot of this. You see vocal tremor only during phonation, but not in spontaneous speech. So that can also be observed clinically. So when such a thing is there, so what we did was we did not advise anything at all in her. She did not have too much of hypophonia. So she was one of those possibly, I don't even know whether, she said that they reported in history that they did not have, or she did not have any kind of a speech problem prior to, the deep brain stimulation. Post the deep brain stimulation, they said that they are not very sure whether she has a problem, but they have come. So now, so that means there is a subclinical involvement that we can see, but they have not. But we don't know whether the subclinical involvement was present earlier or not. So because we know that the sustained phonation is not a regular task that everybody does, unless the person is a singer. Now she is not a singer, so that would definitely not have been done by, but that definitely not have been checked out by her. So such cases. So the management in Parkinson's is highly, or in any of these dysarthria conditions, is highly, it depends on it's a case-to-case basis, and then the management strategy has to be again case-to-case. Yes. Now, okay. Now this neurodegenerative, we know that amyotrophic lateral sclerosis is a condition which can lead to mixed dysarthria because it will have a both spastic as well as a flaccid component. You test the gag reflex, it is exaggerated. You see an atrophic tongue, it is, you see an atrophic tongue. So you put them together and you say, okay, now this patient seems to have a mixed dysarthria. There is a strained voice and so forth. Now, again, here, it is important in the management that we review the notes. So we know that whether it is a spinal onset type or a bulbar onset, or the patient had both spinal and bulbar onsets together. So which means that now when we say spinal onset, and still I say that the patient has dysarthria, it started with a limb involvement, and then progressively there was a speech impairment. So at onset, it was basically the limb or maybe the respiratory subsystem. Now, when the respiratory subsystem gets involved, again, you can have a dysarthric component, but it may not have been evident to them as much. So that is observed in them. So this is in terms of the classification of ALS. So we review notes, we come to a diagnosis, we do or most of us have a dysarthria assessment too, and we can do it, and then you do a oral mechanism examination in detail, you do subsystem analysis and everything, and say finally it is a mixed dysarthria. So in the management, it is important to eliminate exercises in ALS. This is very, very essential. They must not be overloaded at all. Otherwise, the degeneration can be more faster. There are a lot of people who say, who advise, no, you go and you do the lateral movements of the tongue, you go, do phonatory exercises and so forth. So that kind of phonatory exercises, look into the range and so forth. But in cases with ALS, please eliminate any kind of an exercise. So here what happens is that there is the talking itself is a very good exercise for them. So they don't need anything additional. If at all there is something that they can do, I would suggest that they do a relaxed deep inhalation and exhalation. It should not be any of these, rapid inhalation, exhalation. Again, you are kind of stressing the muscles. So that can again cause a problem to them, and the degeneration can be more rapid. So it would be more ease of inhalation as well as the exhalation a few times, and then just leave it. It can be done through the day, if possible in a supine position or in upright position. Supine position, they might find it very difficult because of the type of respiratory muscle that is involved. So so in that case, they will have to sit in upright position, then they need to do. Sorry. So that is one. So as far as that is concerned, the laryngeal system, they don't need to do any kind of phonatory range exercises or phonation or home chant, nothing of that. And what is important is that they need to provide what is called as gaps between speech. That is, they take pauses between speech. So they rest between their lines, they rest between the phrases. They need to rest also that there is, the system is not strained, especially in those with severe cases. In mild cases, they may be able to speak continuously because they will have additional good breath support for speech. But in the moderate to severe cases, it is important for them to pause in between, speak a few lines, then pause in between if necessary, take in that deep breath, continue. So this needs to be explained to them in detail so that they follow these strategies. Yes, and as far as articulation is concerned, initially it is just something like a range of movement of the lip or the tongue. Occasionally can be just told to them, even while chewing, someone or while eating, someone would use the lingual range of movement to clear the bolus, which itself is sufficient for them. So otherwise, they must not go through the other typical regime that we would use for a stroke patient. Or a person with a head injury, because that would create a lot of problem for these people. The degeneration would be more rapid. So eliminate exercises, work on just the breath support, and use or start using alternate communication strategies. Prompt them for that. So when they come for counseling, it is important to tell the family that, look, it can be progressive. Now, in persons with Parkinson's disease, you don't have to tell them that early. But whereas someone who has had a bulbar onset of ALS for about 1.5 to 2 years, subsequent has gone to moderate kind of dysarthria, and that if you ask them to do a phonation or a frication, duration is extremely less. We know that the breath support is receding, and in such a case, prompting them for an alternate more mode of communication would be ideal in the beginning itself. So a proactive approach is very important. Yes, and AACs become are required for them ultimately. So now, this was a case who came to us when he was about 28 years old, and he met with a road traffic accident. So what we did was we found that he had mixed dysarthria. He had a spastic as well as a hyperkinetic type of dysarthria. So in such a case, what we did was to work on each of the subsystems of speech. So we said, okay, respiratory support was extremely less. So we worked on the respiratory subsystem. Then again, the phonation was extremely less. That we worked on that. Then we looked at the resonance. Yes. Now, very often you find that in some cases with Parkinson's, in some cases with the post-traumatic conditions of dysarthria, they do have hypernasality. Now, given that it was 2 years post and he had not responded to any kind of, behavioral strategy to reduce or to improve the velopharyngeal competence, what we suggested was that he could go in for a kind of, palatal prosthesis. So that was suggested to him. However, the family decided that no, they were able to understand. It was not, I would say the hypernasality was not, was kind of moderate. So, it is like, you need to, the intelligibility, if you would rate it, then you would put it something like, you need to maybe ask him to repeat again, or someone who's habituated to listen to him, that is the family has better idea what he's talking about. So that way, so anyway, they didn't go for it, but sometimes we are not able to, push them through these things. So yes, so we did find an improvement in terms of his articulatory precision. Definitely the range of movement, the production of the stop sounds improved, the production of fricatives improved. So all these, and hence the intelligibility of speech also improved. So this is an illustration with post-traumatic case. So we can work more aggressively with them, provided they do not develop other causes. Sometimes they develop, seizure disorder because of this. So in such a case, we need to be, again, we can work on dysarthria very, aggressively. But then, when there is a seizure disorder, you need to look at, if there is no improvement, is there something else that is happening in the brain which is preventing the improvement in speech? So yes, overall, when we talk of dysarthria management, we are talking of managing communication. So how much of speech improves? I started with speech being an important tool to now saying that we are managing communication. I think that is the most important thing that a speech language pathologist has been emphasizing and will continue to emphasize. So the goal would be to maximize the effectiveness, efficacy, or the naturalness. So how natural are they when they get back their speech? Whether it is a post-traumatic or a mild case of PD with all these cases with dysarthria, how much natural are they when they start talking? So that is what we need to ultimately evaluate and address. So in moderate dysarthria, we know that if ALS is worsened, we know that, okay, we try to maintain intelligibility in them by asking them, okay, can you do a little exaggerated movement, maybe repeat it, I will understand. So in those cases, and in severe dysarthric, we know that ultimately to maintain communication, we need to use an alternate mode of communication. Now, from the dysarthria, they can even progress to a stage of anarthria. So that means there is only gestural mode of communication. So ALS conditions can progress to that stage. Some of the PDs can also progress to that stage. And so then what happens now? Can they gesture at all? Are the limbs free to gesture? So that needs to be evaluated later. So did we change our diagnosis from dysarthria to anarthria? So we said moderate dysarthria, now the person is anarthric. So what is the management strategy? So these are the issues in the clinics that we need to keep looking. Now we know that any of these management strategies promote neural plasticity as well as the motor skill learning. Now the question is, if there is a degenerative condition you are training, can it still bring about some neural plasticity? The answer is yes. To some extent, yes. But in severe cases, we do not know how much it actually brings about a change. So we have a lot of things. You restore the lost function, you work on compensation, you say, okay, you modify the rate, I will use the prosthesis, you augment with gestures, use the AACs, and then in other words, we are looking at lifestyle modification. Or in other words, we are asking the person himself, the person with dysarthria, look, you need to accept this. The family needs to accept this. And then, you know, they may have a lot of friends. The friends need to accept. So there is a social dynamics to the whole lot of, you know, social dynamics that we need to, you know, address to in dysarthria management itself. So we know that from now, we know that all these factors that I have told you, a lot of these, they influence you know, the decision making in dysarthria, the medical prognosis, the ICF model, impairment, limitation, restriction, the environment, the communication partners, the motivation, the needs. Should the person get back or should the person not get back? What about the associated problems? What are the motor, the sensory deficits? Yes. Now, what happens in persons with, you know, hearing loss? So that is an issue. Now, that can be a very significant thing. So someone has Parkinson's disease with hearing loss. Then what are we doing? So our dysarthria management needs to be geared to address these issues also. Address cognition. We know that there can be a decline in their cognitive skills over time. So addressing, and then of course the social, psychosocial issues, the emotional issues in them. And overall, is there an access? And if there is an access, is it a hospital setting? It is a clinic, small clinic, doesn't matter. Is the clinician efficient? I think that matters a lot. So what should be the treatment focus? And we know that the duration has to be longer and it has to be pretty intensive in dysarthria management in order to see some changes. So considering all this, all these have to be considered when we talk of dysarthria management. With this, I thank Dr. Natraj again for inviting me to this wonderful, you know, set of symposium that he's held actually. So I congratulate him on this 20th anniversary of JSS, and greetings to all the JSS team here, as well as the students and faculty. Thank you all again. Yes.
Thank you very much, ma'am. It was a
questions.
sir. No questions have been posted as of now, sir. If there are any, we will notify.
Thank you, Dr. Yamini. Thank you for accepting our invitation and also taking part in the webinar. It was very informative lecture, and you have shared your experience, and we hope to make use of your experience at a later stage. Thank you very much.
Thank you. Thank you, sir.
Go to Mrs. Sanjana, please.
It was a very enriching session. The case illustrations that you provided was very helpful in understanding the specific management strategies for intervention of various cases. Thank you very much. On behalf of JSS Institute of Speech and Hearing, I request you to kindly accept the letter of appreciation for being the resource person in today's webinar.
Oh, it's beautiful. Thank you. Thank you very much.
Thank you, ma'am.
We can announce the evening program and tomorrow's program. I mean, day after tomorrow's program.
Yes, sir. So participants may kindly note that we have the fourth session of today's webinar scheduled between 5:30 to 6:30 p.m. Unlike the other days where we began the evening sessions at 4. So kindly note, today we will have the fourth session between 5:30 to 6:30. So kindly make it convenient to join us at the respective time and it is a kind request. Kindly join us by 5:15 p.m.
I announced Monday's program also. Monday at 10
And
o'clock.
also, yes, we have another session on Monday as well. That is on 9th. So we will have the morning session. The details of it will be shared again in the evening as well. So this is for your kind information. Please join us today as well as on Monday. Thank you, one and all. Sir, can we wind up, sir?
Sanjana, Natwas have left the.
Yes, sir. Yes, sir. Yes.
Shall we wind it up? We will meet back in the evening session. Yeah, by
Yes.
Soma Devanga. Yeah, thank you.